My dear friends, in this lecture, I am going to talk about acute liver failure in pregnancy and what are the ways to manage it. And in management, also, what are the ways to diagnose and what would be the differentials. Now, it is known that there is a condition of called acute fatty liver of pregnancy, which is a rare, but which is a quite fatal condition. And this is an obstetric emergency where there is failure of the liver. But besides this acute fatty liver of pregnancy, there are various other causes too, which can cause acute liver failure during pregnancy. So before that, we have to know what is the formal definition of acute liver failure. Acute liver failure is characterized by an increase in PT by 4 to 6 seconds with an INR of more than 1.5 and the development of hepatic encephalopathy in a patient without pre-existing cirrhosis and with an illness of less than 6 months duration. So this is very important, the duration, because once the duration exceeds 6 months, it is no longer comes under the definition of ALF. And the term acute and chronic liver failure defines an abrupt and life-threatening worsening of clinical condition of patients with cirrhosis or chronic liver disease. So this is also important because in ALF, the patient has no pre-existing cirrhosis, whereas in ACLF, it is all the patient will have a cirrhosis or chronic liver disease in the background. So let us go through a walk along this case, and we will try to pick up the salient features of acute liver failure of pregnancy as we walk along this case. A 36-year-old female, G1P1L0 of 32 weeks gestation, was admitted with history of absence of fetal movements for 1 day, malaise, nausea, and vomiting, along with yellow-colored urine for past 2 weeks. The patient had received supportive treatment for acute viral hepatitis at a private clinic and was also detected to be hypertensive in the third trimester and was on tablet alpha-methyl dopa 250 mg TDS. On examination, patient is somnolent but arousable. Temperature is 36.6, heart rate is 104, respiratory rate is 24, blood pressure is 110 upon 60. Neurological findings are insignificant. Patient is icteric with pedal edema, although the edema is mild. Here it is important to note that if the edema is significant or moderate to severe, then again it can rule out acute fatty liver of pregnancy. And in abdomen, it is non-tendered. The USG shows demise of the 30 to 4 weeks fetus along with fatty liver. So what investigations to advise in the background of such findings? So in CBC, it's normal. The platelet count is reduced to 50,000. Peripheral smear is negative for hemolysis. Biochemistry shows raised creatinine, borderline, it's 1.5. Bilirubin is 8. Both AST and ALT are raised more than 10 times. Proteinal albumin, it is reduced mildly. Alkaline phosphatase is raised. Blood glucose is normal. Arterial ammonia is raised. On coagulogram, it is PTINR is 60/3.2. Fibrinogen is 62. FDP is raised 360. Urine analysis shows mild proteinuria. And the serological tests, including Coombs tests, are negative. So what is the differential diagnosis? If we look into the etiologies of acute liver failure in US, we find that paracetamol seems to be the most common culprit because in a much larger number of patients, it is the paracetamol toxicity which causes liver failure. This is followed by some indeterminate or idiopathic causes and other causes, and out of which pregnancy follows a very minuscule percentage of 0.8. So, but in our country, this is not so. And here we get a lot of patients with acute liver failure during pregnancy. And it is very important to distinguish between the causes which lead to this acute liver failure. So if we want to differentiate these diseases, this disease can either be acute or they can be chronic, with acute and chronic presentation in a significantly good number of patients, almost 1/3 of the patients can have acute and chronic presentations. If the presentation is acute, it can be because of a pregnancy-related cause or because of a non-pregnancy related cause. If it is because of pregnancy-related cause and it is early pregnancy, then hyperemesis gravidarum can be one cause. Benign jaundice of pregnancy can be another. Intrahepatic cholestasis of pregnancy. But as the pregnancy advances, then we move on from preeclampsia to HELLP syndrome and acute fatty liver of pregnancy, which almost always occurs during the 3rd trimester and sometimes even in the postpartum period. In non-pregnancy related causes, there can be drug-induced, it can be viral hepatitis, can be gallstones, Budd-Chiari syndrome, alcoholic, toxins, trauma, Wilson's disease, and are being the other category diseases in this category. If it is chronic, it can be because of chronic viral hepatitis, autoimmune hepatitis, non-alcoholic fatty liver disease, which is showing a significant rise in the past decade, alcoholic liver disease, Wilson's disease, primary or metastatic hepatic malignancies. Now, this is indeed a rare cause in the West, but it is not so rare in many parts, other parts of the globe, although it is rare in India. So out of these acute and chronic, we can clearly distinguish between the ones when it is related to the pregnancy or non-pregnancy related. So in our case, a presumptive diagnosis of preeclampsia based on the findings, along with either HELLP because of falling platelets and or AFLP was made. Now, how to distinguish these 4 common causes? The intrahepatic cholestasis of pregnancy, the preeclampsia, the HELLP syndrome, and AFLP, because these are the 4 where sometimes a telltale diagnosis can determine the course of illness and also guide us to the appropriate treatment, which may be different. In case of AFLP, AFLP is indeed very rare, and it is because most of the times the deficiency of the LCHAT enzyme, this is and that is the long-acting acetyl-CoA hydrogenase enzyme, autosomal recessive in nature. So AFLP is indeed rare, but it is very fatal. So diagnosis is very important. So this occurs when with a maternal age of more than 20 years, parity of either nulliparity or multiparity, irrespective of that, multifetal pregnancy, pregnancies carrying male fetus, and occasionally the patient is having a family history. So when the family history is there, which is not there with HELLP syndrome, which may be there with eclampsia and ICP, but is more commoner with AFLP, which should be in the mind. The onset is usually in the 3rd trimester of the pregnancy, or it may even occur during the postpartum. HELLP syndrome occurs in the late 2nd trimester or 3rd trimester or postpartum, whereas preeclampsia occurs in the late 2nd and 3rd trimesters, and so does ICP, intrahepatic cholestasis, that is also occurs during the 3rd trimester. Almost symptoms are similar. There cannot be too much of difference in the symptoms, but if it is a HELLP syndrome, we can see significant, there is peripheral edema is much more, proteinuria is there, and in case of AFLP, also there is encephalopathy. Encephalopathy can be there during eclampsia, but not in preeclampsia. In preeclampsia, we can have blurred vision along with hyperproteinuria, along with other findings, abdominal pain, hypertension. But in intrahepatic cholestasis, it is typically characterized by intense pruritus and jaundice, which is fairly uncommon in the other 3. If we look into the signs, in HELLP syndrome, there is no ascites. In preeclampsia, there is no ascites. In ICP also, there is no ascites, but in AFLP, ascites may be present. And if we go into the laboratory features, we can see that in the aminotransferases can increase by 5 to 10 times in AFLP, but they may increase up to 100 times in HELLP, and so also in eclampsia. And another important feature is that the creatinine will be raised in AFLP as well as in preeclampsia, but not in HELLP or in intrahepatic cholestasis. Proteinuria is not there in ICP, but it will be there in preeclampsia, although it may be absent in AFLP or in HELP syndrome. So these are some of, and of course, about the hypoglycemia, which occurs more early and more severely in AFLP in comparison to all other three. So these are some of the features that can take us to the specific diagnosis onto the condition so that treatment can be initiated early. While HELP syndrome has a fluctuating clinical course because it carries rapid exacerbation within hours or transient remissions, uh, acute fatty liver, AFLP, will rapidly progress to acute liver failure if the infant is not delivered immediately. So the termination of the pregnancy becomes important for the survival of the mother. There is a Swansea criteria for AFLP diagnosis, which includes these features of vomiting, abdominal pain, polyuria, polydipsia, encephalopathy, nausea, ascites or bright liver by the ultrasound, etc., along with the raise in bilirubin, hypoglycemia, leukocytosis, elevated transaminases, and elevated ammonia, and coagulopathy. But for simplification, there is a simplified criteria for diagnosis of AFLP, and that includes the setting, that is either late pregnancy, late second or third trimester, acute liver failure, that is jaundice with coagulopathy and or hypoglycemia and encephalopathy, and 3, with no other explanation for liver failure. So presence of all these 3 criteria is required for the presumptive diagnosis of AFLP. And there is no, by meaning of no other explanation for liver failure, we mean that there is no history of ingestion of hepatotoxic drugs or even Ayurvedic drugs for that matter, negative hepatitis, viral serology, peripheral smear, negative for malarial parasite, etc. Now, let us go back to our patient. Now, considering patient's increasing somnolence and absence of cervical dilatation, the patient was sent for emergency LSCS without a trial of labor, and his patient received 10 milligram of vitamin K, 4 units of PRP, and 10 units of cryo for correction of her coagulopathy along with antibiotic supportive treatment, etc. The CVP was maintained between 8 to 12 millimeter of mercury. The urine output was maintained between 50 ml per hour. Lasix was given intermittently, 20 to 40 milligram SOS. And after 6 hours in the ABG on 4 liters of oxygen by mask, patient had mild acidosis, metabolic acidosis, PCO2 was 32, PO2 was 102, bicarb was 15, and the standard base deficit was 9.6. So what are the possible aberrations in the standard approach? So for that, we have to understand that the principles of management in acute liver failure is that we have to identify the etiology of acute liver failure whenever possible, initiate the specific treatment. So supportive and symptomatic management of ALF when timely transfer to the critical care unit, that is of importance, and early consultation with liver transplant specialists and transfers of patients to liver transplant center when necessary. So what are the tests which are recommended to achieve the etiological diagnosis? If the cause is suspected to be because of drugs or toxins like acetaminophen or Amanita or anti-TB drugs like isoniazid, or if it is a halogen hepatitis, then this has to be investigated on that lines. If it can be because of viral infection, then we have to undertake the viral markers. The vascular problems, this can be seen most often after cardiac arrest, major blood loss, iatrogenic ligation of the blood vessels which are feeding the liver, etc. Metabolic or miscellaneous causes, which can include Wilson's disease, AFLP, alpha-1 antitrypsin deficiencies, autoimmune hepatitis. So we will have to do those specific tests to identify the antibodies for autoimmune hepatitis and the other markers respectively for disease. And in idiopathic cause, despite undergoing all the tests, in 15 to 20% of the adult acute liver failure cases, we cannot come to the specific cause. So avoidance of further hepatotoxic agents in combination of supportive care is the typical therapy. Now, a few lines about the PCM poisoning in pregnancy. Now, it encompasses 4 stages. One is the latent stage, early stage, the toxic stage, and the recovery stage. So in the early stage, we can see that it may be asymptomatic or may have anorexia, nausea, vomiting, and abdominal pain. In the latent stage, patients may be asymptomatic or may improve slightly, though not much. There can be relapses, hepatotoxicity happening, but it is not obvious clinically or just by looking at the laboratory parameters. In the toxic stage, it is worsening liver injury and symptoms with abdominal pain, nausea, vomiting, confusion, jaundice, and along with multi-organ failure. And in the recovery stage, if patient survives to this stage, then hepatic function fully recovers eventually. Now, in patients with paracetamol in poisoning, if there is concern for possible acetaminophen intoxication and there is known ingestion of acetaminophen for more than 8 years ago, we can have to start acetylcysteine and evaluate if we can stop it safely. If it is not more than 8 hours or we don't know, we check the serum acetaminophen level and the ALT. If the acetaminophen level is more than 10 and the ALT is less than 50, we have to check for the other conditions like whether it is a single ingestion, whether the ingestion is less than 24 hours, reliable history of timing, no alcoholism, no synergistic drugs, no extended release formulation, and no gastric emptying. If the answer is yes, then we go for the acetaminophen level above the normogram. If it is no, we go for we start IV acetylcysteine. And if the acetaminophen level is not above the normogram line, no treatment is needed. So if we find the ALT more than 50 units per liter, again, we have to start IV acetylcysteine and continue till acetaminophen comes below 10 and ALT comes below 50. And when the negative acetaminophen level and normal ALT is reached, then no further treatment is given. So we have to know the drugs that may amplify the hepatic injury, which includes particularly the antitubercular drugs, isoniazid, rifampicin, along with anti-seizure medications like phenobarbital, phenytoin, carbamazepine, some antibiotics like Cetron, then anti-HIV drugs, the older ones, they like the zidovudin. And we have to see that they don't delay acetylcysteine pending return of the labs. We have to start immediately. And if it is more than 24 hours of ingestion, the patients may have hepatic injury with negative acetaminophen levels. So such patients still benefit from an acetylcysteine until hepatic injury resolves. So we will have to keep note of these facts when we treat paracetamol or acetaminophen toxicity. For Budd-Chiari syndrome in pregnancy, we will have to arrive upon a diagnosis. Once we arrive upon a diagnosis, we go for anticoagulation and treatment of the underlying cause. We look for whether ascites, esophageal varices, or liver failure is present. If present, then the choice is TIPS. If it is TIPS is ineffective or unfeasible, we have to consider angioplasty or stent or surgery. If the answer is no to the presence of esophageal varices or liver failure, then we follow them up. And if TIPS is performed, then also we have to follow them up. And once we consider angioplasty or stent or surgery to be ineffective or unfeasible, then we have no choice but for liver transplant. So let us go back to the case. The patient develops severe tachycardia and tachypnea after 12 hours in the ICU. Chest X-ray shows pulmonary edema. There is falling urine output and rising creatinine along with worsening encephalopathy. So this is in this scenario, what should be the principles of therapy? So we have to think about the treatment of hepatic NCEF, endotracheal intubation for grade 3 or 4 hepatic NCEF under adequate sedation with propofol and analgesia such as fentanyl. Bowel cleansing with lactulose enema we've used commonly. Saline enema was used earlier. Administration of oral lactulose and unabsorbable antibiotics. However, the efficiency and safety of this approach is still unproven. Prevention of cerebral edema. So we have to elevate the head end of the bed to 30 degrees so that the venous drainage is facilitated. Maintain patient's neck in neutral position. Allow spontaneous hyperventilation or normoventilation for that matter, which is maybe better, and allow spontaneous hypothermia if it is feasible, and maintain the ICP. So first line of treatment for reducing cerebral edema is intravenous administration of mannitol, but considering the nephrotoxicity, one might have to avoid mannitol and go for hypertonic saline, in which case, again, it should achieve a serum sodium levels of 145 to 155. In cases of rescue therapy for cerebral edema, we can go for intravenous administration of additional boluses of mannitol, therapeutic hypothermia, although it is still debatable. Intravenous administration of indomethacin and total hepatectomy if donor graft has been identified and patient is refractory to medical management. Treatment for impending brainstem herniation can be forced hyperventilation if it is not a contraindicated because of the patient's general condition. Now, the summary of the quadruple H interventions and therapeutic targets for acute liver failure in patients with severe NCAF, we have to consider hyperventilation, hemodiafiltration, hypernatremia, and hypothermia, of which again, hypothermia is and hyperventilation has found a mixed response. Earlier, it was shown to be successful in 4 different trials, but later on 2 trials have shown that there is no difference, but still there is no consensus. And therefore, whatever mechanism is adopted, the therapeutic target should be clear. And we try to maintain this target in terms of PCO2, blood ammonia, serum sodium, and the core temperature. So if hyperventilation has reverted back to normal ventilation and the others unchanged, we can continue with normal ventilation for a reasonably prolonged period of time to ensure that the patient's hemodynamics remain stable. Now, after for 72 hours, patient is still anuric, hemodynamically unstable on inotropes, ABG showing metabolic acidosis, hyperkalemia, and the base deficit is gone up to 15. So what form of renal replacement therapy should be used? Now, if you see the pathology, we have to understand there is alteration in the endocrine function, tubular function, systemic changes, along with the changes in the renal hemodynamics with this condition, as well as because of the pregnancy, there is the release of relaxin, progesterone, etc., which affect the renal hemodynamics to a particular extent. Plus, there are structural changes leading to pelvic alveolar dilatation with hydronephrosis, increased pore size leading to physiological proteinuria, which also mandate early renal replacement therapy. So functional renal failure in patients with ALF is inferred after examination of urine reveals no evidence of tubular injury, that is a normal sediment, urine sodium less than 10 millimoles per liter, and a 1.5 liter volume challenge, ruling out pre-renal azotemia. So in case of life-threatening complication of AKI, we have to start RRT. If it is not a life-threatening, we can optimize the hemodynamic status and discontinue the nephrotoxic drugs whenever possible. Go for a regular assessment of the clinical progress. And if the patient is having persistent AKI and one of the following, like progressive fluid accumulation, blood urea more than 18, worsening acidosis, persistent or worsening hyperkalemia, persistent oliguria, worsening non-renal organ dysfunction, anticipated large fluid load, or administration of nephrotoxins, then we have to consider starting RRT early. There is no difference in the outcome between whether you use hemodialysis or SLED or RRT, but CVVHD is preferred, and that is possible through CRRT because we have both the components of convection as well as diffusion, as we know that in hemodialysis, it is only because of diffusion. Here, the slow clearance that the CRRT causes produces less fluid shifts and maybe more pertinent in the patient is hemodynamically unstable. One important point to consider in such patients is infection or sepsis, because bacterial infection is present in 1/3 of ACLF patients at presentation to the tertiary referral hospital, and this is further increases by first week. The most frequent infections are spontaneous bacterial peritonitis, pneumonia, although UTI and bacteremia are also common. The acute phase proteins such as the CRP and PCT are reliable biomarkers. Patients who respond to treatment for bacterial infection have significantly reduced mortality. So antibiotics should not be delayed in suspicion of infection, and administration of albumin is recommended in patients with spontaneous bacterial peritonitis for prevention type 1 HRS. Now, can these patients need and be benefit from liver transplantation? Now, delivery and supportive care may improve liver function and allow avoidance of transplant. When ALF becomes advanced or the CLF with decompensation occurs, then liver transplant can be recommended. Evaluation and determination of the need for liver transplant is generally made according to the criteria, which are similar in all aspects to the non-pregnant patients, and there is no difference about it. So to summarize the conditions, if it is a secondary to viral hepatitis, the distinguishing characteristics include mild to marked elevation in the serum transaminases, a positive viral serology, prominent inflammatory infiltrate with hepatocellular disarray. If it is because of acute fatty liver of pregnancy, we have minimal elevation of transaminases with little, if any, inflammatory infiltrate, but there will be prominent microvascular fat deposition in the hepatocytes. Toxic injury, we have history of drug exposure to the antitubercular drug, etc. Cholestasis of pregnancy will be characterized by pruritus, elevation of bile salts, and there will be cholestasis with little inflammation. Severe preeclampsia will be characterized by hypertension, edema, proteinuria, and oliguria. To summarize, the take-home message is acute liver failure in pregnancy should be evaluated for both pregnancy-related and also for non-pregnancy-related causes. Acute fetal liver of pregnancy is a rare but fatal condition with high maternal and fetal mortality, and acute fatty liver of pregnancy should be evaluated and excluded whenever in all such patients. HELP syndrome occurs in less than 1% of all pregnancies, but it may be seen in up to 20% of pregnancies which are complicated by preeclampsia, and they can lead to acute liver failure, particularly when associated with liver hematomas or liver rupture. Therapy is similar in all these patients to that of non-pregnant patient, and no life-saving intervention should be withheld for the patient. Thank you.